All right. Well, thank you, everyone. And thank you also to all of our faculty who are spending this late evening with us and are happy to answer any questions that you have. So please feel free to put them in the chat. We would love to hear what you have to say. We were trying to answer some of the questions throughout the entirety of the session, but I think it's always good to elaborate when we have our faculty on board. So with that said, actually, you know, I think a lot of for those who are constantly treating macular edema, we're using steroids. The question always comes up with SLT and the value of SLT in the setting of steroids. So I'm going to turn it over to Michael. Would love to get our glaucoma experts' thoughts on, the how would they manage steroid-related ocular hypertension? What's their go-to, and how do they escalate therapy in a systematic way?
Yeah, I love the systematic way part. So I'll take a first crack at it, and then we can let the others take a try as well. So I think problem with steroid response is it frequently generates pretty high pressures, and so laser may not be quick enough, right? It doesn't work right away, and so it's not always the first thing I try. But if the pressure's not that bad, I think it's reasonable to think about laser because the fundamental problem is, meshwork dysfunction. As the glycoproteins get deposited in your trabecular meshwork and it clogs it up. So it's reasonable to think about it and can work. But if the pressure is going very high suddenly after, a Kenalog injection or something, you may not have the luxury of waiting 6 more weeks for that to actually do its thing. Otherwise, it's drops if they work, and then, if you have to move on to something surgical, always a possibility in those folks, especially if they have like sort of a depot steroid requirement or long-term steroid requirement for other kinds of disease.
Yeah,
Shalini, you want to go next?
sure. Yeah, I agree with what Michael's saying. And of course, adjusting the drops if we can go to a lower potency steroid, if that's possible, that's always an option. But I have to say, these days, with the availability of our much safer, less invasive surgery options like MIGS, especially working, in the angle, my threshold is pretty low for taking the patient to the operating room for something like a canaloplasty or a GAT to lower that pressure. On occasion, I've had, young patients, uveitis, who've had steroid response and we're doing this back and forth. Okay, now we've got to treat them, but now we're dealing with the pressure. I had one patient that I did bilateral, canaloplasty and partial goniotomy, and it worked beautifully. So I think, in those patients that we know that are going to require longer term steroids, it probably makes more sense to just think about, well, how are we actually going to treat it long term? And surgery is definitely a reasonable option. And then, of course, if that doesn't work, there's, more invasive procedures we can do, but we can save those for later.
That's so I sort of love that answer, right? Because if we're thinking that this is a problem of resistance at the trabecular meshwork, 10 years ago, it would be very common to do a glaucoma drainage implant for somebody who comes in with uncontrolled pressure on medical therapy. Is the glaucoma community shifting over to trying to do angle-based surgery to manage steroid-related ocular hypertension and trying to avoid glaucoma drainage implants as first line?
Oh, I would say definitely. I mean, at least in my practice, I think, again, my threshold for doing any kind of angle-based surgery, if a patient is on even one drop and then I'm taking them back for cataract surgery, I'm definitely considering what am I doing to treat the angle. There's also now suprachoroidal devices as well that we've been utilizing, and I've found some really good success with that. Some of those patients that have pressures of, in 30s, I recently had one who was getting recurrent anti-VEGF injections and had persistently elevated pressures. And I did a canaloplasty plus the suprachoroidal graft, and that's worked really, really nicely. And imagine that was a very short procedure. They recovered in less than a week or two, and they were back to the retina doctor getting their injections. So they had both, issues addressed in a very timely manner, which was great.
I will say the one challenge on some of these folks, if they're being treated for a uveitic condition, I still have some pause about taking out meshwork or, just because we've now exposed the blood. We've destroyed all the what's remaining of the blood aqueous barrier if there was much to begin with. And, downstream from all that stuff is your venous system, right? So you can get blood reflux. And so you're getting all the stuff that's in your blood back in the eye. And so there's some question, I think, for uveitics, whether that's the right thing to do. or not. Certainly, if you just have a plain steroid response from being treated for CME or something, I think it makes sense. But I think we have to be a little careful. And I'm not sure what the right answer is. I'm not saying it's wrong. I just think we don't know yet whether that's going to be worse or better for people who've got a uveitis-based problem.
All right, fantastic. Well, let's take that back just a little bit. And there was a question from the audience, is SLT as effective for patients with pigment dispersion syndrome? And I know we've kind of covered that, but what I think would be really helpful is maybe can you articulate what circumstances where you would advocate for SLT and what circumstances where you try to avoid it?
Again, with the light trial, I'm very much an advocate for offering SLT to all of my patients as first line, and even in the pigment dispersion. Now, if there's very heavy pigment, I may tend to just treat 180 degrees, and of course, it's dependent on the severity of their disease. If it's very, far along central island, I may be concerned about a pressure spike, and if this is going to tip them over to needing, emergent surgery. So it's all going to be very dependent on the patient, but I definitely think SLT is a very appropriate treatment option.
So,
Can I interject? So going back to kind of Michael's point, and this relates to SLT, in your patients who maybe have a steroid response, who are the chronic DME patients or the chronic post-surgical CME patients who are getting treated with steroids versus the uveitis, do you feel differently using SLT in those two groups, or is it equally effective for both?
Yeah, I mean, I think, oh, sorry. I was going to say with the uveitis, I probably maybe hold back on doing SLT. Steroid response is a different issue, but the SLT, I typically am not offering that as a first line, and I don't actually think I've used that in my recent practice.
Is it easy to, discriminate between who has, if they're uveitic and they have elevated intraocular pressure, is it due to, and they're getting frequent, local steroid treatments? How sure can you be that it's, steroid related versus, it's due to some other, mixed mechanism from the uveitis? I mean, that's obviously something that we love to be able to rely on your guys' expertise, because it's challenging, obviously, for us in the retina world.
Yeah, I'm not sure we have a clear answer to that, right? A lot of times you can't tell why their meshwork is not working, right? Is it one or the other? Some of it may be time course, right? So if they've been quiet for a long time, would be on high dose steroids and the pressure goes up, that's probably a steroid problem. Whereas if they're poorly controlled, obviously then it's something else. And obviously other findings, right? So you got to break out the gonio prism and look at the angle. And if it's plugged up with iris from chronic inflammation, that's a different story than looks wide open and they've had high dose steroids for a while. I think so. Some of those is just history and your findings will help you tease apart some of that.
Yeah,
Going back to SLT as first line therapy, we actually had sort of discussed it among the three of us. And I think, the light trial that we talked about during the presentation really does give very good evidence that SLT is a great first line treatment. But I think one of the challenges is sort of, do you offer it or do you recommend it? And that sounds like maybe a subtle difference, but I think it's really important for your patient to hear what you recommend. And so I think that is really shifting. I think there are practices that really recommend SLT as first line therapy, and then still a lot of practices that offer it and then, sort of leave it up to the patient. And I'm always surprised how many of the patients don't want to have laser as their first treatment. And I think if you told me tomorrow that I have glaucoma, I'd be like sitting in the chair getting an SLT.
Yeah. Yeah, I think that's a really great point, is that I think it sort of depends on how we educate our patients about a particular therapy and its value. Now, Danica, there was actually a question for you that came up in the audience. I think you had answered it to some degree in your case, which I thought was really fascinating. You had this really asymmetric presentation of glaucoma, and the question was, do you recommend treatment for just the right eye, which had more advanced glaucoma in this young patient? Or would you treat both eyes? And maybe can you elaborate on your thought process a little bit more on that answer?
Yes, so this patient that I presented had primary open angle glaucoma, which is really a bilateral disease. And I think we all recognize asymmetry as really a hallmark of glaucoma, asymmetry top to bottom within an eye, but also asymmetry right to left eye. And so what this patient's right eye looks like is just a sort of a prediction of what his left eye, I think, is going to ultimately look like. So if I have a secondary glaucoma, I'm convinced it's a secondary glaucoma, then I might consider treating one eye. But in a case that's primary open angle, I'm going to treat both eyes.
Yeah, I think it's great to think about glaucoma as I put it in the chat and during the session. It's really a person disease, meaning, it's a thing that's going to affect both of your eyes if it's a primary open angle kind of glaucoma. It's almost always asymmetric. But as you say, you don't want your good eye to end up like your bad eye by ignoring it. So I think I'm in the same boat there. I will treat it if we think it's a primary kind of glaucoma for sure.
Perfect. So, actually, we've got some really amazing retina docs here on the line, and we've got about just under 10 minutes of questions left, and some really excellent questions from the audience. So there was one question as it was pertaining to macular telangiectasia, which is that if we're seeing this for the first time, how soon should they see a retina specialist? So, Carolyn, what are your thoughts when you see and diagnose somebody with MacTel? What's your sort of evaluation, and then what's your approach to sort of managing this with your retina specialist?
Yeah, certainly. I find that OCT angiography is huge in terms of early detection. And often if it's very, very early disease, the patient's still 20/20, and now we're able to actually diagnose it and detect it that early. It's usually something I'm monitoring in-house, but if it's starting to affect patient's vision or they seem young to have the disease, and I know that they still have a long lifetime of the disease course process, especially now that we have an FDA-approved treatment option for macular telangiectasia type 2, I'm going to be referring those patients to a retina specialist now.
Got it. So, Eric, tell us a little bit about that trial, and who qualified and essentially to get essentially revokinogene tarotetecel and or NT501, and who are the patients that you think would be ideal candidates in your clinic to get this therapy?
Yes. So obviously, in terms of who, might be the best candidates, I think, Carolyn kind of hit it on the head. I think we want to get these patients in, the chair and get them imaged early. I think that, one of the big things with MacTel is there's a very, heterogeneous progression of the disease, right? And so we're obviously looking for patients who have progressive disease. The challenge is if you look at some of the, clinical trial data, specifically the post hoc analysis, if you look at the patients who had the largest benefit, right, all comers, there's about a 55% reduction in outer retina or, ellipsoid zone loss. But the patients who had the greatest benefit were those who actually had earlier stages of disease, right? And so I think that, speaks to, who we should be looking for and who we should be treating. It's a challenge, obviously, because it's not as simple as an intravitreal injection or a laser, or a topical drop, because we're talking about an implantable device that's there, potentially for their lifetime. There's some, data from previous trials in other disease states in which some of these devices have been in place for 10, 15 years. And so I think, from a safety perspective, we feel pretty good about having them, implanted. But again, those are very small numbers in previous clinical trials. And so, as we've learned, anytime we, see something utilized on scale in the real world, we can, find different issues that can pop up. But yeah, I definitely think we want to, catch them early, but I do think sort of longitudinal sort of follow up to really establish sort of rate of progression is this how I'm approaching it. I think one of the challenges is that their Encelto is still really rolling out, right? They haven't really started manufacturing at scale. I think the first, device implanted outside of clinical trial was just in August. And so many payers, really, this is a very expensive device, are still struggling with coverage. And so I think coverage determinations is also going to be a big part of how we eventually roll this out kind of nationwide.
All right. So I think that your points, and I love that case of MacTel, well, really the two cases, because the earlier we identify it in the clinical trials, you had to have ellipsoid zone loss in order to even qualify for the study. And essentially smaller areas of ellipsoid zone loss, younger patients did better relative to those, and also diabetic patients did better relative to older patients or areas of larger ellipsoids and loss. So really using your imaging to identify them at earlier stages is arguably the most valuable. And I completely agree with Eric. The progression is nonlinear. So sometimes you may see a patient who sort of looks remarkably stable 5 years later. And actually, just recently, I recommended somebody to have the Incelto implant, and we are currently working on that prior authorization because I followed this patient since 2014, and we can see the progression of ellipsoid zone changes very sort of consistently getting worse over that 11-year window. So it's pretty remarkable how longitudinal OCT follow-up can really shape your opinion on the value of this treatment, watching her go from 2020 vision in 2014 to now 2080 and 2060 vision today. So really something that I think could be super valuable. Carolyn, I want to kind of go to you because I loved your cases of non-perfusion, how you identified neovascularization on these beautiful ultra wide field, OCTA images that you sort of montaged together. But there was a really important question that was posted, which is, what are you looking for on cross-sectional OCT, specifically the thickness of the retina that would clue you into looking for areas of peripheral non-perfusion?
Yeah, so typically when the retina is non-perfused and it's been long-standing, you'll have atrophy of the inner retinal layers. And I think that's difficult to image in cross-section in the peripheral retina, but certainly in the macular region, if you're seeing thinning, anytime there's thinning, I'll always ask my students or my residents, is it inner retinal thinning or is it outer retinal thinning? And then I think that can help you kind of differentiate what's causing it. And, particularly in diabetic retinopathy, it's going to be inner retinal thinning. And you can kind of isolate that out sometimes with the ganglion cell complex. And this is where it becomes complicated because we have a lot of patients who have diabetic retinopathy and are also, say, glaucoma suspects. And then we have GCC loss or ganglion cell analysis loss. And we're trying to say, is this diabetic retinopathy or is this glaucoma? And I think that's, always a challenge.
Absolutely. Eric, what are anything else that you'd want to add to that?
No, I mean, I think I would comment that Carolyn's images are some of the best I've seen. I think, what her cases really highlight, though, is that, I think we are, seeing and are capable of sort of a paradigm shift in how we're imaging these patients. Fluorescein angiography is, great, as I think we had talked a little bit about, if we're looking for leakage. But again, I think for the vast majority of our encounters, I think what we really want to know is there neovascularization present? Is there non-perfusion present? I think OCT angiography really provides all that. And I think it's easier on patients, it's easier on our clinics. And so I do think that it, should really be the way forward. And I anticipate as we get faster lasers, she showed some great montages, but we'll, hopefully be seeing, aura to aura OCTAs, available, at every corner here, hopefully in the next several years.
Yeah.
Completely agree.
Just one clinical tidbit to those listeners. If you're looking at the macular OCT in a patient with diabetic retinopathy and you are seeing a lot of areas of inner retinal thinning, and you're sort of thinking this may be moderate NPDR, which is what you previously defined it, you may be underestimating the severity of the disease. And I think that's a really great opportunity to consider fluorescein angiography or these montage OCTAs to look for areas of non-perfusion outside of the macula, which we know are major risk factors for progression to proliferative diabetic retinopathy. So that should really clue you into say, do I have the right diagnosis in terms of my degree of diabetic retinopathy, and what am I worried about? So we'll be back shortly for closing remarks. I want to say thank you so much to all of the faculty here for being willing to answer these questions. Thank you so much to all of the listeners here for all your great feedback. This only works as an interactive format. We hope these cases were informative. So really big shout out to Shalini, Michael, Eric, Danica, Carolyn. You guys were all amazing, and it's my pleasure being a part of this with you.